All right. Hello and welcome to this month's Simon Says Expert Series. My name is Dr. Carla Fisher. I am the Director of Breast Surgical Oncology at IU Health and an Associate Professor of Surgery at the IU School of Medicine. As you may know, this month is Breast Cancer Awareness Month, and today we're excited to share with you some recent clinical and research advancements which are focusing on preventing lymphedema in breast cancer patients as well as other cancer patients. Lymphedema is a condition that causes progressive limb swelling, and you're going to be hearing a lot more about that today. Joining us today are Dr. Hassanein and Dr. Mithun Sinha. Dr. Hassanein is a plastic surgeon with IU Health and an associate professor of plastic surgery at the IU School of Medicine. He is an NIH-funded investigator with a laboratory focused on breast cancer-related lymphedema. Dr. Mithun is an assistant professor of plastic surgery at the IU School of Medicine who specializes in the fields of implant-associated immunological complications and wound healing. So we definitely have some experts speaking with us today. Thank you, Drs. Hassanein and Sinha, for joining me today, and we look forward to your talk.
Thank you, Dr. Fisher, and thanks for having us in this Simon Cancer Expert Talk series. Looking forward to the discussion after this little presentation that we have about an important topic of lymphedema. So it's just want to see if everyone can see the slides being shared right now.
It looks good.
Okay, so we have no disclosures at all relevant to this talk. And so lymphedema is a very, very difficult condition. It's very common after mastectomy in the treatment of breast cancer. And it occurs in about 33% of patients that undergo axillary dissection, which is removal of the lymph nodes, complete removal of the lymph nodes, and radiation in the treatment of breast cancer. And unfortunately, for lymphedema, it's characterized by swelling of the limb, and it can get progressive and large over time. And unfortunately, there's no cure for lymphedema. Now, there's treatments for lymphedema. Compression is a mainstay of treatment. Our physical therapists do a wonderful job of initiating that and doing that. And that includes static compression, pneumatic compression, debulking surgery such as liposuction work. And there are also microsurgical interventions that we can do to improve lymphedema. And with these treatment options, we did a systematic review of the literature a few years ago and found, despite these treatment options, as you can see, they all end up in continued compression. Really, there's no treatment to get rid of lymphedema where it reverses everything completely, and then there's no issues anymore. And this is an example of liposuction. And so we even use it for fat grafting sometimes for breast cancer patients that can benefit from fat grafting to the breast and kind of repurpose the fat. But as part of lymphedema, the arm enlarges with fluid initially, followed by over time, fat deposition and fibrosis. And so this is kind of the fat used for the fat grafting. And here we're doing it for breast cancer patients. So liposuction can reduce the limb size by removing the abnormal fat part of lymphedema. Another treatment when patients have lymphedema is lymphovenous bypass. And here you see we're mapping the lymphatics in an arm. And then we identify the lymphatics in patients that already have lymphedema and bypass them into veins in the area to sort of avoid, it's almost like a detour for the diseased areas and the fibrotic areas. And we also do vascularized lymph node transfer, and we prefer a technique using the deep flap lymph nodes around the deep flap pedicle, which we've written about. Let's see. And so when you have lymphatic injury, the problem is you have initially fluid, adipose deposition, and fibrosis. And this triggers this inflammatory cascade with CD4 cell infiltration, various inflammatory cytokines. And this kind of inflammatory cascade creates the fibrosis and adipose deposition. So that makes it very difficult to reverse. So even though we have these treatments that make things better, they're not really stopping this inflammatory cascade and reversing it. And so that's why really the best treatment for lymphedema may be just trying to prevent this lymphatic injury and lymphatic dysfunction with fluid accumulation. So this is called what we call ILR, immediate lymphatic reconstruction. And so during the axillary dissection, the disrupted lymphatics are identified and microsurgically connected to veins in the area to sort of reestablish flow in and out. And this is an example in this video of immediate lymphatic reconstruction, this preventative surgery. And the glowing you see is a dye proving that there's flow across the connection for the lymphatics. And we were kind of early adapters of this technique, this immediate lymphatic reconstruction. When Dr. Fisher and I both got here in 2017, it's something we discussed doing, and our center started doing it. And we wrote up one of the initial early American series, really the second American series published on immediate lymphatic reconstruction at IU, this preventative surgery. And we found that 9% of the patients developed lymphedema. So it was down from the 30% of patients that we see normally. So it was effective at decreasing the risk. And we also did this systematic review of the literature a few years ago. And we found that from the studies that were published at the time, 6% of patients acquired lymphedema compared to 30% did not have this immediate lymphatic reconstruction. The best data we really have about immediate lymphatic reconstruction, there's a randomized prospective study going on at a big cancer hospital, Memorial Sloan Kettering in New York. They've recruited 99 patients, and they found that 9.5% of patients get lymphedema after ILR, or which the immediate lymphatic reconstruction, compared to 33% that do not get immediate lymphatic reconstruction. That's at 2 years. And this is an ongoing study. This is kind of the preliminary results with long-term follow-up. So it seems like, and we've also published a couple other things about that it's safe to do breast cancer reconstruction, tissue expander reconstruction at the same time. Patients in our series had a similar infection risk and similar skin necrosis risk with or without immediate lymphatic reconstruction. The problem with immediate lymphatic reconstruction, it requires specialized centers, people trained in what they call super microsurgery, which uses very tiny needles, very tiny suture. Human hair is what's considered the size of 6.0 nylon, which is a type of suture diameter. And basically the diameter is half every time you go up, 7.0, 8.0, 9.0. And we use 12.0 nylon a lot of times for this. So it's really just halving the size of human hair over and over again. So you need specialized microscopes, specialized instruments, and it's really not widely applicable. It just could be done at a few centers, and we're the only center in the state of Indiana that does immediate lymphatic reconstruction. So is there a way to be able to try to prevent lymphedema with wider applicability? And that was kind of our goal of our laboratory. There's something called tissue nanotransfection technology. That is this direct transcutaneous gene delivery device using silicone nanochips. It uses a power supply, and it's a non-viral way of genetic gene delivery. And it's been used for tissue reprogramming through various applications throughout the body. And our goal was, we asked the question, can tissue nanotransfection technology be used for lymphedema? Is that possible? Can we upregulate lymphangiogenicis in other means? And so we adapted the mouse tail model of lymphedema, which is very common, the most common model of lymphedema in an animal model. We create a full thickness skin excision at the base of the tail and transect the lymphatic channels. There's 2 large lymphatic channels in the mouse tail. And these mice always develop lymphedema pretty quickly, consistently. Unlike in humans and large animals, if you remove the lymph nodes and provide radiation, it takes on average a year after the lymphatic injury for lymphedema to occur. But in mice, it's quickly. So it's a beneficial thing. And so we did a proof of concept with TNT with the mice, and Dr. Sinha can kind of talk us through this slide a little bit.
Thanks, Al, and thanks, Carla. So here what you are actually seeing is that at the molecular level, when we try to visualize certain tissues, we try to go behind the markers. Can we go just one slide back?
Yeah, I'm trying.
Yeah, so we try to go behind the markers. So each tissue will have some specific protein or genetic marker. And if you can stain them, you can visualize those tissues. So with the lymphatics, we have this particular protein, which is called as the PROX1, which is in the upstream or in the upper level of which controls all the lymphatic formation. And that is shown over here in green. And endomucin is a marker for the veins. So as you can see, the animals were delivered the PROX1 gene through tissue nanotransfection. Now, the proof of concept is if you're delivering the gene, then the gene product, that's the protein, should be expressed. And that's what we are seeing at the bottom, that on left-hand panel, you have the TNT sham, which just received nothing, no gene, and the right-hand one, which received the PROX1 gene through the tissue nanotransfection, which Dr. Hassanein mentioned. And you can see increased level of the green fluorescence, which is linked with the PROX1 gene, which is an indicative of the lymphatic expression. Next slide, please.
Yeah, so we established that with this proof of concept that tissue nanotransfection can be effective at delivering genes in the mouse tail model of lymphedema. And now we're wondering, can it be used to prevent lymphedema if it's given at the same time as a surgery, as a preventative approach? And so for that, we had essentially two groups of mice. One received the PROX1 TNT delivered gene on the day of the surgery, of the mouse tail surgery. In the sham group, the control group did not. They received TNT with just the plasmid backbone, and they did not receive the therapeutic. And what we found was the mice that received the TNT delivered PROX1 had preserved, did not have tail swelling like the other mice group. So basically it prevented lymphedema and tail swelling in these mice when PROX1 was delivered with TNT. And then we also assessed lymphatic function, and we found that the mice that underwent TNT delivered PROX1 therapy had preserved lymphatic function compared to the mice that did not. So TNT was effective at keeping the tails smaller, preventing the swelling, and also preserving the lymphatic function. Histologically, we assessed the tails as well. Dr. Sinha can kind of go through some of our findings.
Yeah, so some of the classical ways by which we determine the lymphedema, at least in animal models, is the increase in the thickness of the epithelium. So if you look at the H&E figure, which is the top panel figure in pinkish color, and you see the pointer of the arrow, the right-hand arrow, you will see it is pointing towards a layer called as epithelium. So if you see on the TNT sham, which just received the backbone, it is thicker versus that which received the PROX1, which is thinner, which is an indicative that the thickness of the epithelium, which is indicative of lymphedema, is being tackled when you deliver TNT PROX1 prophylactically to prevent lymphedema. The other characteristic feature of lymphedema is collagen deposition. So it is a type of protein that gets deposited in your skin. So often you will associate, if there is a wound, you see a scar tissue, that is nothing but a deposition of collagen. So this also, such deposition happens in the lymphedema patients, and you diagnose it through a staining called as the picrocereus red staining, which stains the collagen. On your left-hand panel, which is the TNT sham, we see more collagen intensity than the one on the right-hand panel, which is the TNT PROX1, that is the animals which received the TNT PROX1 delivery. Also, podoplanin is another marker for the lymphatic, just like we discussed about PROX1 before. Podoplanin is another marker. It's sort of a mature marker of lymphatics, gives you an indication of more lymphatic formation. So what happens in lymphedema, the lymphatic formation goes down. So what we are trying to show over here, that when you do a TNT PROX1 delivery, you have more lymphatics. As you can see from the left versus right comparison, you see more red dots or red structures indicative of the podoplanin. Next slide. Okay,
so we did RNA-seq for sequencing of the two groups as well. Dr. Sinha, who's an RNA expert, can talk us through this too.
So RNA-seq is a mechanism by which you can look into the global transcriptome profiling. So we usually, Homo sapiens will have somewhere around 22 to 23,000 genes, but we make like over 100,000 different types of proteins, and each of those proteins have an RNA transcript from which that protein is made. So what does RNA-seq? So there are two ways. One is the bulk, one is the single cell. This is a bulk RNA-seq, using the lymphedema tissues from those two groups of animal, one which received the TNT sham and another which received the TNT PROX1. It gives us an idea about what is happening at the inflammation level, whether the inflammatory genes are upregulated or downregulated. Can we rescue inflammation post the TNT treatment? So exactly that's what we saw over here, that the inflammatory responsive genes like L1, CCR4, TAC1 were downregulated once with the TNT prox1. Also, interestingly, what we found, VEGF-C, which is an inducer of angiogenic pathway. Angiogenic pathway is the pathway that governs formation of your blood vessels and your lymphatic vessels, was upregulated following the TNT prox1.
So the TNT delivered prox1 seemed to prevent tail swelling in the mice. It preserved lymphatic function. It histologically showed characteristics that were unlike lymphedema compared to the other group. And our RNA sequencing showed essentially decreased inflammatory response genes, increased VEGF-C, which is a marker of lymphangiogenic marker, and a decrease in abundance of transcripts in the inflammatory pathway. And so to actually try to visualize functionally the lymphatics well and quantify lymphangiogenesis, we employed a technique which is very well developed at IU, actually, which is intravital microscopy, which is a way of doing microscopy in live animals. And so to really preserve or assess lymphatic function, we want to have live animals and look at their lymphatics. And so this study was done with injecting a dye that would essentially retroorbitally localize into the veins, and also injecting a different dye, FITC green, which would go into the lymphatics. So that was interstitial at the mouse tail. And these mice were immobilized under the microscope, under the intravital microscope, and we use what's present at IU, the 2-photon SP8 multiphoton microscope to visualize these mice. Mithun, anything else to add about this?
Yeah, so Dr. Hassanein's group is the first group to show intravital microscopy on a lymphedema tail model. And this is very important, as he mentioned, that when we are taking histology or when we are taking sections, whether it is from a patient sample or from an animal model, we are freezing that on a frame of time, and then we are looking at what could have happened at that frozen frame of time. We are not looking at it actively while the condition is getting developed. This is the only way, the intravital microscopy, that you can do or you can image in a live animal how their lymphatics are behaving. And Dr. Hassanein will share some wonderful videos where you can appreciate this technique. So it is easier said than done. And this group did the first time, and we have published this now. It's an elegant technique to show that the proof that the mechanisms or the techniques that Dr. Hassanein's laboratory has developed to prevent lymphedema prophylactically is working, at least at the animal model.
And part of the impetus for this was there is quite a bit of literature out there where you could induce lymphangiogenesis in models of lymphedema, but they're not functional. So there's lymphatic density there, but they're not really doing much. So visualizing it in real time, in real life, in a live mouse was kind of a key to be able to show the functionality. And what we did find was there was increased lymphangiogenesis, and we assessed this by branch points. So the prox1 delivered TNT mice had greater lymphatic branch points, indicating lymphangiogenesis, than the control mice, so that there was significantly more lymphangiogenesis in this mice. And this is real-time live animal lymphatic functioning vessel with lymphatic flow that we're able to visualize in a live mice with this intravital microscopy. So it shows a functioning lymphatic as well. So that was one study that we completed about preventing lymphedema using tissue nanotransfection technology, which is a much more clinically translatable way to deliver genes therapeutically than using a viral carrier. There's been barriers to using adenoviral gene delivery and concerns. And so TNT can focally deliver it to the area directly without concerns of kind of widespread delivery. And so this was an important study that we did in the mice showing that it's effective for doing that and hoping to translate it clinically as well. So the next kind of concept that we studied was something called a lymphatic delay phenomenon to see this exist. So there's something called a vascular delay phenomenon, which has been known about in plastic surgery and flap surgery for hundreds and hundreds of years. And so the concept is, if you're transferring tissue and you partially raise the flap, so you don't completely raise the tissue to transfer it, you just partially do it, and you delay about 7 to 10 days. So it's partially ischemic, and then finish delaying it 7 to 10 days later after that delay, it increases flap viability and it's more effective. So, the tip of a flap can become necrotic and not make it if you don't. And then if you do this vascular delay, it works better. And this has been going on for hundreds of years. This is a Tagliacozzi flap in Italy that was done for nasal reconstruction, where they just kept this tissue from the arm on the nose for they actually did it for months. It turns out that wasn't necessary. And this is an example clinically of trying to cover this wound in this patient that's had radiation for a cranial tumor. And normally if you try, it's just all radiated tissue. I was trying to get away from the radiated tissue area. Normally, if you try to transfer that tip of the flap there, it's really not in the correct angiosome for perfusion for the supraorbital vessels. So I just partially raised the flap and then transferred it about a week later, and it was effective. So that's the vascular delay phenomenon. It induces vasculogenesis and angiogenesis. Our question was, is there a lymphatic delay phenomenon? Is there such thing for lymphatic vessels? Is there something with partial injury of lymphatics that could be protective of potentially lymphedema? So we want to see this proof of concept of whether or not there's a stage disruption of lymphatic vessels could be protective against lymphedema in our animal models. And we term this lymphatic preconditioning rather than lymphatic delay phenomenon. And for that, we use our same lymphatic mouse tail model of lymphedema initially. And so we had one group of the normal mouse tail model of lymphedema with full thickness excision and disrupting both lymphatic chains. We also had a second control group where we did the same full thickness skin excision, disrupted one lymphatic chain in that area, and on the same day, the same surgery, disrupted the other lymphatic chain more proximally at a different site. So both lymphatic chains were disrupted the same day, just in two different sites. And finally, our lymphatic preconditioning group, our experimental group, had the full thickness skin excision, disruption of one lymphatic chain at that site. They were left alone. And then a week later, we came back and disrupted the other lymphatic chain at a proximal site. It's difficult to go to the same surgical site and disrupt it because of scarring and whatnot. So that's why we did it that way. And then what we found was the lymphatic preconditioning group had less lymphedema in terms of tail volume than both other control groups, than the standard control group and the modified control group. So it seemed to work. It seemed to decrease lymphedema by a stage disruption of lymphatics. And then we also did lymphangiography and designing green near infrared lymphangiography and showed preserved lymphatic function in these mice tail as well. And so for rigor and for a more clinically translatable model, we adapted and used something called the Heinlein model of lymphedema and optimized it. Now, it's not as often that this is used in the literature because there's relatively been inconsistent results compared to the mouse tail model. So we optimize this model overall. So that involves radiation. We radiate one hind limb 1 week before the surgery. And then we come back 1 week later after the radiation. We inject a blue dye in the foot, isosulfan blue, in the paw. And then this localizes into the lymphatics and stains them blue. We disrupt the major lymphatics in the hind limb and remove the popliteal lymph nodes in the hind limb as well. So taking out the lymph nodes, disrupting the lymphatics and radiation, and then suture the skin back down and redrape it. And so we're able to get consistent results with this hind limb. We take measurements of the paw thickness as one outcome variable, and that's the main outcome variable. And we leave the other hind limb alone for comparison to have an internal control as well. So these mice were able to get consistent swelling with the way we approached it. We also did lymphangiography with indocyanine green and also showed worse lymphatic function in the hind limb compared to the control limb as well. So it wasn't clearing the dye that localizes into the lymphatics. And so for rigor, we use this animal model for the same lymphatic preconditioning study to see if stage disruption makes a difference. So group 1 was the normal Heinlein model of lymphedema, where we took out the popliteal lymph nodes, radiated the mice first, took out the popliteal lymph nodes, and disrupted the lymphatics. And for group 2, we had, which is our experimental group, the lymphatic preconditioned group, we initially did the same radiation of the hind limb, and then a week later, we disrupted one lymphatic chain with a semi-circumferential skin incision only. We left the lymph nodes alone, the popliteal lymph nodes alone, and left the other lymphatic channel alone. And then we came back 1 week later and did the popliteal lymph node removal and also disrupted the other lymphatics. So we did the same, ultimately the same lymphatic disruption, but staged it by a week. And so what we found was the lymphatic preconditioned group, the one that had the stage disruption of lymphatics, had less lymphedema and preserved lymphatic function than the normal standard lymphedema group. They had less paw thickness. Their paw thickness was normal compared to the contralateral limb. And also with, in terms of lymphatic function with lymphangiography, they also had preserved lymphatic function. So the dye cleared really quickly and worked really well, indicating preserved lymphatic function compared to the normal model. So in summary, with these two studies that our lab's doing and are both active areas, tissue nanotransfection technology can be used to focally deliver PROX1 to prevent lymphedema. We're targeting other targets as well. So we're really focused on junctional proteins. There's some changes in junctional proteins that occur in lymphedema, and we're trying to prevent that by targeting with tissue nanotransfection technology. And also this lymphatic delay phenomenon, this seems to be a thing. We did this proof of concept study, and it's a whole new concept, a whole new world for lymphedema, and with the potential for clinical translation. Perhaps, for an axillary dissection, we can do axillary reverse mapping, where we inject dye in the arm and then see what the important lymphatic lymph nodes are from the arm, and maybe preserve those during the first operation. And a breast surgeon like Dr. Fisher can perhaps tag those important lymph nodes, come back a week later, and then remove them, remove the clips from those areas, and remove the rest of the lymph nodes in the area. And maybe staging the lymph node removal can give the body the opportunity to have protective effects. And we're trying to look at the mechanism for this lymphatic delay phenomenon, how it works exactly, and why it happens. So these are some of the areas that we're actively looking at in our lab right now. And so I just want to thank our lab members, and we have a great team. Dr. Sinha is my co-investigator in this, and he brings a lot of expertise in RNA and other issues to really have the results that we've been able to have in the scientific rigor. And then Ganesh Mohan is a postdoctorate who's been there for several years now. And then Shanur Ahmed is a general surgery resident who's been in the lab. He's a second year in the lab, who's done phenomenal. And Lucy Halswell was our med student through the MedStar program, who's contributed significantly during her year in the lab. And also our funding through the NIH NHLBI with a K08, and NIAMS as well with an R21. The DoD has provided funding as well as foundational funds, in the Indiana CTSI as well have helped this go through. So this was just a presentation, kind of the overview of what we're doing in the lab now.
That was great. So that was a wonderful example, I think, of some of the translational work that's being done at the IU Simon Cancer Center. So thank you to Drs. Hassanein and Sinha. We have about 15 minutes or so left, and we've got a couple of questions, so I'm going to throw them out there to you guys. The first question has to do with the lympha procedure, which is similar, kind of the same as the ILR procedure you talked about at the beginning of the talk. So what percentage of these procedures are being done with breast surgery patients? Do you feel that all patients who have lymph node removal, sentinel lymph node, and axillary dissection should have therapy and be fitted for garments initially, or only with complaints of fullness?
So very good questions. So first of all, the indication for the immediate lymphatic reconstruction, the ILR, is really only for axillary dissection. Sentinel node biopsies, the risk of lymphedema is too low to really make a difference. And everything we do surgically has a downside. In this case, they're really minimal downsides, but it is extending the operating room time about 45 minutes or so. And also there's a lot of preserved lymphatics with a sentinel node biopsy, and the risk of lymphedema is low. So really those patients wouldn't benefit much from it. So we basically try to do it at IU anytime any patient gets an axillary lymph node dissection. Me or one of my partners, Dr. Lester, Dr. Danforth, Dr. Vonderhaar, Dr. Bamba, perform immediate lymphatic reconstruction and are there to try it out. In terms of whether these patients should get compression, we try to work to get with our physical therapists to get compression very early. So they usually are referred to our physical therapists prior to any of the surgery to get plugged in, and oftentimes they can be fitted for garments. One thing that's been shown is early compression with early postoperative swelling after an axillary dissection can actually alter the course and potentially prevent lymphedema as well. It's very effective. So it's not just sort of trying to treat the arm length. There's a mechanism of some sort where it can be preventative of lymphedema actually progressing to full-blown lymphedema. Some patients get early postoperative swelling that does not become lymphedema, and compression is really key to that happening, I think. So we try to get these patients in for compression into our physical therapists very early, before surgery, and then anytime there's any kind of issue postoperatively.
The next two questions I'm going to pair together because they're kind of similar. So prehab is when we have our patients meet with, we're used to rehab after surgery recovery, but prehab is when we're having them see physical and occupational therapy prior to surgery for some of these patients. Do you suggest prehab and a return follow-up at a certain time post-op to check for lymphedema? So what's the monitoring for that? And then also, does exercise play a role in preventing or helping with lymphedema?
Yeah, so definitely we try to do prehab on all of our patients. And that's also part of getting them plugged in with our physical therapists. In terms of follow-up, so after the patients learn about what to look for lymphedema, they could proactively call for earlier follow-up if they notice some swelling. We see them post-operatively for an early post-operative visit. And then typically I follow these patients, and a lot of them need breast reconstruction too for, usually every few months. And then I see them for years afterwards, a lot of times with breast reconstruction as well. So they're followed pretty closely overall. What was the other question? I can't see it on the screen.
If exercise plays a role?
Yeah, exercise is really helpful for keeping lymphatics functional and moving lymph through the lymphatics. So the muscle pump lymphatics are a low pressure system. There are some valves. The muscle pump around the lymphatics forces lymph through, and it makes a big difference of decreasing swelling potentially. So being active and exercise is very helpful to combat lymphedema.
We talk a lot about genetics and genomic tests in medical care, and especially in oncologic care these days. So this is a good question related to that. Are there genetic determinants that make someone more susceptible to developing lymphedema?
Yeah, that's a great question. So most of what we talk about and what we're focused on is secondary lymphedema, and that's lymphedema caused by injury to the lymphatic system, typically post-surgical. In the United States, the most common causes after breast cancer treatment. There's a whole nother kind of lymphedema called primary lymphedema, which is really about 1% of patients with lymphedema. So it's much more rare, but there's a large and very well-known genetic component to that with genes that are well described for that. And so some of these patients, they'll have familial lymphedema. A lot of times it involves lower extremity swelling. It could be at birth, it could be congenital or delayed into kind of adolescence, or even adult onset primary lymphedema. And I see patients with lymphedema throughout the state of Indiana. So I still see a good portion of these patients that all of a sudden their lower extremity, they're in their 30s or 40s, or lower extremity is swollen and there's no other good cause. And a lymphoscintigram shows it's lymphedema. And that's really a delayed onset or tardive type of primary lymphedema. And so those have a much more well-known genetic influence that's really well described. The FTL gene is very important for that. there's something called Meigs syndrome that has a big genetic influence. In terms of secondary lymphedema, there probably is. So the fact that 70% of patients don't develop lymphedema, there's a couple known risk factors for developing lymphedema in these patients: high BMI, being obese, the radiation. There's taxane-based chemotherapy. So there's the amount of lymph nodes removed. Those are all known variables, but still 70% don't develop lymphedema. And I think some patients have a predisposition to have lymphatic dysfunction with these, aside from the known variables. That's one area that we just don't know well yet. We haven't characterized yet. And then we're hoping to, and that's in a kind of another arm, a clinical component of our lab research is trying to figure that out. Anything else to add to that, Mithun, or?
Yeah, I think you have addressed it. It's the primary lymphedema, which is the close to like 18 to 20 different genes, which deletion or less expression can lead to primary lymphedema. But when it comes to the secondary lymphedema, which Dr. Hassanein's group is primarily investigating, the role of the genetic component could be primarily towards, increasing the severity of the disease at times, and also about how, so say for example, in the developmental biology, you have some genes firing up to give rise to your hands, your eyes, your livers. Your liver has the genes for your brain as well, but they don't express over there. So whenever there is an injury, that portion of the body has to revert back to part of its developmental regimen, because they have to repair that tissue. And lymphedema, because it's secondary lymphedema, happens after removing the lymphatics. So it has to go back to regenerate those. Now, there is something we call in genetics as epigenetic modulation, that is the genetic memory that you have in your body. So how much that memory has been perturbed with, how much that memory is existing, will result in whether or not you end up developing lymphedema, and even if you get, what will be the course of the outcome and the severity. So it's much more subtle, the play of the genetics, or much more complicated than in the primary lymphedema, where it is far more direct.
All right, we've been answering some pre-submitted questions, as well as questions that have been submitted during the talk today. Just a reminder, as we begin to wrap up, we want to open the floor to any additional questions. Now's your time. So go ahead and submit them in the comment box below or in the chat if you're joining us on Facebook, and we will try to cover all of them before we finish up. I have another question for you guys about men and breast cancer. It's something we don't talk about as much. Men can certainly develop breast cancer as well. Can they develop lymphedema too, and is it treated differently?
Yeah, it's a great question, and absolutely they can. We see it more often in melanoma because obviously there's a breast cancer related lymphedema is much more common in women because breast cancer is much more common in women in general. But men get it quite often in melanoma with lymph node dissections, and can get it with male breast cancer with an axillary dissection and radiation as well too. So kind of it's not like the Y gene is protective against lymphedema. It happens just as common. And Dr. Fisher's actually has expertise in male breast cancer as well. I don't know if you want to add anything more to that, Dr. Fisher.
No, I'd say the biggest thing in terms of men with breast cancer, we're doing a lot more research on it, because traditionally all the ways that we treat men with breast cancer are the ways we've learned on women with breast cancer. And we know that there are differences. So we would tell you that we treat lymphedema exactly the same in men with breast cancer. That's probably the right thing to do. But maybe for some of the things we do for men with breast cancer, we need to be doing them differently. So I think that's a growing area of interest and research. All right. Well, I think we're staying on time and finished up with the questions that have been submitted. So I want to thank Drs. Hassanein and Sinha for their expertise and great work in this important problem. And thank all of you for joining us this month for this month's Simon Says. You can find a recording of today's session and information about upcoming sessions at cancer.iu.edu/Simon Says. Thank you.
Thank you.
Thank you, everybody. Take care.